Okay, so now we are going to discuss the actinomycosis station. A 25-year-old female patient with Crohn's disease on steroid and present with a 4 cm facial ulcer. 25-year-old female patient with Crohn's disease. She's on steroid, now present with a 4 cm facial ulcer. So this is a 4 cm facial ulcer. What is your diagnosis based on this scenario? So this is cervicofacial actinomycosis. So patient is an immunocompromised because she is on steroid. She also has autoimmune disease like Crohn's disease, and now she has developed this uh, this actinomycosis. So cervicofacial actinomycosis is a chronic disease characterized by the abscess formation, draining sinus tracts, fistula, and tissue fibrosis. It can mimic a number of other conditions, particularly malignancy and granulomatous disease. Okay, so chronic fistulas and sinuses, these can mimic malignancies or granulomatous disease and should be included in the differential diagnosis of any soft tissue swelling in the head and neck. So yes, this is a general rule that whenever you have a chronic sinus or fistula, and especially in the head and neck, so you go for suspicion of malignancy or granulomatous disease. So cervicofacial involvement is the most common manifestation of actinomycosis. Okay, accounting for 50% of all cases, while central nervous system, thoracic, abdominal, and pelvic actinomycosis occur less frequently. So cervicofacial presentation is the most common for actinomycosis. Causes of the lesion in this patient, so he is immunocompromised and steroid therapy and Crohn's disease. Which test will you do? Wound swab for gram stain and microscopy, culture and sensitivity. So you will go for gram stain, okay, and then you go for culture and sensitivity. So this will give you the result. I&D, incision and drainage. Shoot golden yellow pus. What is your diagnosis? So this is actinomycosis. What are the granules? Yellow. These are sulfur granules. Okay, so 6 weeks of follow-up. Patient develops sinus and the wound not heal. What could be the cause? So local causes: presence of debris or necrotic tissue, infection in the ulcer, osteomyelitis, and tissue hypoxia. Systemic causes can be diabetes mellitus, immune deficiency, malnutrition. Medication can be corticosteroids because they immunosuppress. You know, um, they can increase lymphocytes, they can cause lymphocytosis, but they decrease neutrophils. So your first line of defense. So local causes: presence of debris, uh, and if a wound is not healing, so this can be the cause. These can be the causes. Presence of debris in necrotic tissue, infection in the ulcer, osteomyelitis, tissue hypoxia. Systemic cause can be diabetes mellitus, immunodeficiency, malnutrition, and the medication can be corticosteroid. Type of actinomycosis bacteria. So it's a gram-positive anaerobic filamentous non-spore forming bacteria. Gram-positive but anaerobic. Common sites for actinomycosis: face, neck, thorax, and appendix. So yes, in appendix this also occurs. For example, in appendix, the scenario will be like, you have done appendectomy for a patient, and the patient come back with for like 2-3 weeks after, and then there is a drainage from the wound side like pus. So you must be thinking the, oh, this appendicular stump may be bloated, but it's all okay and all right, and he's taking food and passing stool and he's fine abdomen wise, but there is pus draining and there are the yellow pus granules. So always think about actinomycosis. Where exactly in the neck, jaw, angle of the mandible, cervicofacial actinomycosis. Patient develop mandible osteomyelitis. What are the causes? How can you get osteomyelitis in mandible? So there can be direct trauma, which exposes the bone. There can local sepsis after dental operation from sinuses. There can be chronic wounds like this actinomycosis wounds, and sometimes there is some tumors. The blood over these some leukemias which can also causes the mandibular abscesses. Causes of enlargement of local lymph nodes in this case, so infection, yes. Reactive follicular hyperplasia of the lymph nodes will cause enlarged lymph nodes. Could inflamed lymph nodes turn into tumor? What could it be? Yes, it can. In the when there is infection in the lymph nodes, or there is immense or extensive follicular hyperplasia and division of the lymphocytes, sometimes it converts into lymphoma. What is the cell responsible for bone formation? So they are osteoblast. Resorption is by osteoclast. Cells found in prominent in acute and chronic inflammation. Okay, so what are the prominent cell in acute and chronic inflammation? So acute inflammation manifested by vascular changes, edema, dolor, pain, predominant neutrophils infiltration will occur, and here you have these infiltrations. Chronic inflammation is characterized by infiltration of the mononuclear cells, which include macrophages, lymphocytes, and plasma cells. So, tissue destruction induced by persisting offending agent or by inflammatory cells. Attempts of healing by connective tissue, replacement of damaged tissue, accomplished by angiogenesis and particular fibrosis. So, what happens actually in chronic? Why acute inflammation converts into chronic inflammation? When the cause or the inciting or triggering agent is persistent. For example, there is a foreign body, so there will be first acute inflammation, then it will convert into chronic inflammation, and the cells will be replaced by macrophage, lymphocytes, and plasma cells. And sometimes the macrophages coalesce together to form the giant cells. So you get the granuloma. So granuloma will contain the epithelioid cells, then surrounding by these macrophages, giant cells. So they can also ask you the structure of a granuloma like this. Okay, so this is the last question of the actinomycosis station. So function of osteoclast. So bone resorption and remodeling is the main function of osteoclast. Yes, so osteoclast and osteocytes. So osteoblasts function produce bone matrix, osteoid, make type 1 collagen and other matrix proteins, line new bone surfaces and follow osteoclast in cating cones. Receptors, parathyroid hormone, vitamin D, glucosteroids or glucocorticoids, estrogens, prostaglandins, and interleukins. So remember this collagen 1. So bone has collagen 1. So how to remember this? So you can remember this by this. So if you split the bone word into B and 1, so this is collagen 1. So bone has collagen 1. So osteoblasts always produce osteoid and making collagen 1 and other protein, and then there occurs the mineralization in this osteoid, and we have this bones. And the receptors on osteoblast, for example, they are influenced by the parathyroid hormone because they have the receptors, vitamin D, glucocorticoids because it will cause then resorption of the bone. Estrogen, they can cause mineralization or the strength of the bone. When there is no estrogen, for example after menopause, there will be osteoporosis. Prostaglandin and interleukins. Osteocytes. So osteoblasts surrounded by bone matrix represent 90% of bone cells. Function, maintain and preserve bone. Long cell processes communicate through canaliculi. Receptors, PTH release calcium. Calcitonin do not release calcium. CD, calcitonin causes deposition. CD. In alphabet, C and D are together, so they will cause CD. Osteoclast, large multinucleated cells derived from the same line of the cells as monocytes and macrophages, and so these are actually the macrophages of the bones. Found in house sheep lacunae, causes bone resorption, and receptors are calcitonin, estrogen, interleukin 1, rank L. The receptors inhibited by bisphosphonates. I will share the picture of this. I'm going to share the picture of this, and I'm going to share the picture of this microscopy of the basal cell carcinoma.